Achilles tendon injuries are generally classified in one of two ways. The first is as a tendinopathy. This could be termed as a peritonitis or peritendinitis, formerly known as Achilles tendonitis. Or it can also be a tendinosis, which is a degeneration of the tendon. The other category of classification is rupture. Generally, the mechanism of injury is going to be very similar to other lower extremity problems. There may be a training error that's taking place. There could be a DIF overload. Additionally, there can be changes of running surfaces from soft to hard. There can be anatomical or biomechanical problems that lead to Achilles tendon issues, and there can also be footwear problems. Signs and symptoms include things such as diffuse edema within the tendon. During the acute stage, the tendon may appear sausage-like because of the diffusely swollen condition that is occurring there. There may be diffuse pain along the entire tendon, or it may only be localized to a few centimeters. There can be palpable tenderness on both sides of the tendon. There may be tender nodules present. A person may complain that they have morning stiffness during dorsiflexion, and they will also potentially complain that walking downstairs is more painful than walking upstairs, simply because they've got an eccentric contraction walking downstairs versus the concentric when moving upstairs. The manual muscle test that we're going to use is really a classic tendon response. The person will have a strong but a very painful contraction with eccentric tension. Diagnosis for a tendinopathy is going to be generally clinical, but you can see here if an MRI is used or maybe a ultrasound, you may also be able to pick up some of the issues within that tendinopathy. Treatment for tendinopathy is generally going to start out conservative. Obviously, we want to try to correct any of those underlying causes, but we may also ask for eccentric training to take place. In my experience, ultrasound is one modality that seems to really help the person depending on the severity of the tendinopathy. If conservative measures don't work, we will move on to corticosteroid injections. We may even move on to surgical type interventions. In the case of an Achilles tendon rupture, we need to keep in mind that this is something that is more likely to be seen in people who are over 40 years of age, although there are certain sports where you may see this in younger folks, such as gymnastics. The mechanism of injury for a rupture is generally some type of eccentric overload. So a person who is landing, shooting a basket, and their foot is forced into dorsiflexion. But it can also occur due to direct trauma. These people are going to be in their 40s and could be weekend warriors that are having problems with this. When there is a rupture, it most commonly occurs about 2 to 6 centimeters above the calcaneal insertion. This is going to happen because you really have a decreased blood supply and a narrow region that leads to a predisposition of rupture of tendons at this site. Signs and symptoms of a rupture. Well, initially you might see a small hole defect in the tendon if it's not a complete rupture, but progressively you will see edema with hemorrhaging that obscures a direct palpation of the tendon. The edema is going to move into the ankle and foot. The person may say that they had a history of transient sharp pain in the area. When a person actually ruptures the tendon completely, they tend to report a sensation of having been hit or kicked in the leg. They may complain of a sensation of popping or snapping, and then obviously because of the rupture, they will have dysfunction. There are 3 special tests that are looked at for sensitivity and specificity. And as you can see here, the Thompson test is going to be your best bet and actually a pretty easy test to perform. The Thompson test consists of simply squeezing the calf and watching for the foot to plantar flex. The Copeland test is a little more complex, and a lot of people aren't going to use that test. But with a Copeland test, you're going to place a blood pressure cuff around the calf itself, and you are going to basically inflate that cuff. The cuff starts at 100 millimeters of mercury, and you're going to move up to 140 millimeters of mercury. During that time, you should expect to see a little bit of plantar flexion taking place. If you do not have that plantar flexion, then there's a chance that it has been ruptured. Range of motion wise, we are going to obviously see an increased dorsiflexion because there is no Achilles to stop the foot from moving too far past its normal range of motion. The manual muscle test, you will find a weak and painless contraction of the gastroc and soleus. If it is a partial rupture, there probably will be pain. Diagnosis can be done through an MRI. They may also use an ultrasound, and what they're really looking for is a lot of edema in that area. The treatment for a rupture is going to be one of two things. If the person is a less active individual, they will probably not do that surgery because it decreases the risk of complications and it increases the risk of re-rupture. However, if the person is physically active, surgery will be indicated.